Very good. So thank you again for joining us. And this year, we will have 2 teams with 4 debaters. This is the first time at APACC where we have 4 debaters instead of 2, making the arguments as to why you should vote for or against our proposition that Dr. Stefan introduced. The team trying to convince you that long-acting injectables should replace oral PrEP medicines include Jennifer Ho and N. Kumarasamy. Jennifer is a global health advocate who has been based in Thailand for over 20 years. She also is the regional coordinator for the Asia-Pacific ChemSex Symposium. Dr. Kumar is the chief and the director of the Infectious Diseases Medical Center at Voluntary Health Services in Chennai, India. He also directs their clinical research site, conducting multiple antiretroviral drug trials. On the team arguing that long-acting injectables should not replace oral PrEP medicines are Rayner and Danvic Rosadiño. Rayner is an assistant professor at the School of Public Health at the National University of Singapore. Among his academic and community leadership activities, he is vice president of Singapore's National Society for Behavioral Health. Danvic is the head of the program and innovations team at the community-based organization LoveYourself in the Philippines, which provides HIV and STI prevention and treatment among a range of other services. He also co-chaired the World Health Organization's Guideline Development Group for the global guidelines on long-acting cabotegravir for HIV prevention. And we are honored to have all 4 of our experts with us for today's debate. In terms of the structure of the debate, we will soon be asking you to vote, so please have your mobile phones ready to connect to the online voting website. I'll be showing you a QR code shortly. After we take the first vote, each of our debaters will present 6-minute statements with slides. The order of the speakers will be those in favor first, followed by those against, with Jennifer, followed by Rayner, then Dr. Kumar, and then Danvic. We will then have time for audience questions and comments, and we hope all of you will participate. After that, the debaters will each give a 2-minute closing statement in the reverse order. We will then ask you all to vote a second time. The voting will be done through this Mentimeter platform, so you can capture this QR code, but please do not vote yet. You can also connect through the URL that's there with the code. The screen that should come up includes the image on the far right, and I will do my best to calculate the proportion of people who change their vote the second time in order to confirm the winning team, which is the one that changes the most minds. Okay, so QR code is still up there on the top right. So now we would ask you to consider whether you think that yes, long-acting injectables should replace oral antiretrovirals for biomedical HIV prevention in the Asia-Pacific region, or if you think that no, long-acting injectables should not replace oral antiretrovirals. So please go ahead and submit your first vote. Going to give you a moment. Please capture that QR code. We're going to take down the slide shortly and transfer over to our speakers. So hopefully everybody who wanted to vote had a chance to do so. So we can go ahead and take my slides down and bring up the slides for our first speaker, who will be Jennifer Ho. So Jennifer, if you could come up. You're not supposed to show the vote yet. Please don't show this vote. Take the vote down. Stop the slide. Please don't show. Okay. Please stop my slides. Stop my slides. And bring up the slides for Jennifer Ho. So please switch the slide now. Yes. Next, Jennifer Ho. Slides. Okay. Thank you. So Jennifer will be our first speaker. Thank you. Let's welcome Jennifer.
Thank you so much, Annette. Good morning once again. My name is Jennifer Ho, and thank you again for the opportunity here today to speak in support of the proposition. Let me figure this out. It's not working. Oh, yeah, okay. I want to be clear, we're not talking about removing options. We're talking about doing what's right today based on science and based on the realities of people's life. More now than ever, we must align our HIV response with lives people are actually living, not the life that we want them to think, that we think they should live. So to replace means to shift the default. It means making long-acting injectables like cabotegravir and lenacapavir the primary biomedical prevention strategy in our HIV prevention program. Oral PrEP stays available, but the center of gravity in our biomedical strategy must shift because oral PrEP is not reaching, it's not retaining, nor is it responding to those most at risk. So let's start with who we are failing today. A trans woman stares at before she even speaks. A sex worker hiding her pills to avoid violence. A young man afraid his family will find out about his PrEP. A person who uses drugs stay away from care because of fear. These aren't rare exceptions, they are daily realities. And we're failing people with systems and tools built for ideal clients, not real lives. 33 of 39 countries in Asia Pacific still criminalize key populations through laws against identities, behavior, or survival. And yet, it is peer educators and community groups and networks holding this all together, filling gaps and making oral PrEP works. But they shouldn't have to fight this hard. We cannot treat our way out of the epidemic, and we need prevention tools that meet people where they are. We heard during the opening ceremony that Asia Pacific is falling behind. By end 2023, only 204,000 people were on PrEP. That's just 2% of the 8.2 million target under the UNAIDS Global AIDS Strategy. Dropout is high. In Thailand's Princess PrEP study, only 30 to 40% would remain on PrEP after 6 months. MSM accounts for 46% of new infections in adults aged 15 to 49. PrEP access is still urban center, leaving out rural, remote, and mobile populations. And here's a wake-up call. 3 of the world's 4 fastest growing epidemics are in our region, the Philippines, PNG, and Fiji. In the Philippines alone, cases have risen by over 500%, especially among youth and MSM. And we're also seeing more late-stage diagnosis due to stigma and delay in testing. So this is not a moment for business as usual. Oral PrEP doesn't fit unpredictable, criminalized, or stigmatized life. You can't take a pill every day if it means being outed, judged, or arrested. We're also seeing rise in chemsex practices in urban cities across Asia Pacific, settings where sex, substance use, and stigma collide. In these moments, daily or on-demand pills often fail. People need protections that doesn't rely on memory, timing, or disclosure. As someone say, I don't fear the side effects, I fear the side eyes. Now, imagine a tool that's designed for the real world, not a perfect world, and this is what long-acting injectables offer. There's no daily pill to remember, no bottle to hide, no need to plan around every sexual encounter. For someone whose life is unpredictable, whether due to unstable housing, movement between cities, or fear of stigma, this is a game changer. Long-acting injectables are discreet. They don't broadcast your status, your behavior, or your health choices. They lift the mental weight of daily decision-making, and perhaps most importantly, they allow people to stay protected without having to explain themselves to family, to employers, or to strangers in clinic. And this is what it looks like when prevention actually fits real lives, when it doesn't depend on disclosure, visibility, or perfect routine. Long-acting injectables are not just another product. It is also a pathway to equity. Not everyone needs the same thing, but everyone deserves what works. Long-acting injectables help us catch up to the reality of how people live. They level the field for those furthest left behind. And this is not just a theory. Demand is real and growing. People are asking for fewer visits, less exposure, and greater autonomy. When it comes to PrEP, the barrier isn't willingness. The barrier is delivery, delivering what people actually need. Survey after survey shows strong interest. 84% of Thai youth, 70% of MSM in Vietnam, 74% of MSM in China, and MSM in Malaysia show clear preference for long-acting injectables. And across 16 countries, the PrEP appeal study found that 40% of MSM and 39% of trans women prefer long-acting injectable. So we're not asking, is it possible to make long-acting injectable available? We're asking, what is the right thing to do? Rates of HIV decline in Asia-Pacific are 3 times slower than the global average. And in some countries, they're going the wrong direction. This isn't a failure of science. It is a failure to deliver what people actually need. So we must move from slow adaptation to strategic acceleration. And long-acting injectable give us that chance. They're realistic, respectful, and responsive. And they keep the hope of ending AIDS alive. With a new tool, we can get there, but only if we lead, not follow. So my debate partner, Dr. Kumar, will shortly walk us through the clinical and scientific evidence behind long-acting injectable, and together we believe that LAIs are not just new options, they are the right next step. Thank you.
Thank you, Jennifer, and now we invite Rayner to the stage.
Great, thank you so much. Well, thank you so much for the opportunity to be here, and I would like to thank Jennifer for our esteemed opponent Jennifer for sharing her opinion on that we should be replacing oral PrEP with a long-acting injectable PrEP. One thing that I wanted to point out today is that there's a definition from the Oxford Dictionary on the definition of replace, and the definition of replace is to actually have something or somebody to be used instead of something or someone else, or to do something instead of someone or something. And I think that premise is something that we should be questioning in terms of what the proposition has proposed to us, right? They're saying that we are not removing options, but in fact the statement over here that long-acting injectables should replace oral antiretrovirals for biomedical HIV prevention in the Asia-Pacific region means that we are indeed removing options over there. And so, instead of opinion, I'm going to offer you 2 additional facts over here. So one thing is that I've been talking to many of you here, many delegates here at APACC 2025, and actually many of you already believe that we should not be replacing oral PrEP with a long-acting injectable PrEP. So in some sense, maybe the debate has been won even before it was begun. But I think that's aside from the point. The second thing that I want to point out as a fact is that I'm a person living with HIV. One thing that that led to my seroconversion was that after exposure event, I actually went to the doctor. And I sat in front of the doctor's chair, and I was interested in getting post-exposure prophylaxis. However, I was not able to get PEP in my hands because of issues such as stigma, inequities, access, and costs eventually. And so I think these are really important implementation considerations that we need to consider when we think about PrEP and PEP and other prevention products as well. And it's because of these implementation considerations that we should not be replacing oral PrEP with a long-acting injectable PrEP. I'll share with you a little bit more today. And one thing that I want to remind everyone is that the proposition here, by asking us to replace oral PrEP with HIV, long-acting injectable PrEP, wants us to imagine a world where we only have long-acting injectable PrEP only. So that is the premise that they're offering. So one thing that I also want to highlight is that I think this is really interesting because I'm supposed to offer a clinical perspective, and my very esteemed colleague Danvic is going to offer a community perspective, but I'm not an HIV clinician. So one thing that I think is also pretty apt is because I am not arguing against, or we are not arguing against the clinical efficacy of long-acting injectable PrEP. In fact, what Jennifer has shared, in terms of the community voices, these are all really valid, and it's something that we all can agree on. But one thing that was not covered really in detail is the implementation considerations, right? So while we have a high-level approval from WHO, many different high-level bodies, saying that we should definitely increase access and scale up of PrEP, especially long-acting injectable PrEP, because of its clinical efficacy. The thing is that not all countries in the Asia Pacific have approved any form of long-acting injectable PrEP at all. In fact, for example, this is guidance from Singapore, where I'm from. It says that, in recent years, they've acknowledged that long-acting injectable PrEP has been found to be an effective alternative form of PrEP. However, this recommendation will not cover it because, this is not something that we have approved in Singapore. Many countries have also only just approved oral PrEP. And, one thing that we need to remind ourselves is that we do not even have that much data or the science backing up the implementation of long-acting injectable PrEP in the Asia-Pacific region. So, this is something that really, really is a big impediment for us to really imagine a world where only long-acting injectable PrEP exists. So in terms of implementation, there are two things here. One thing is, there are implementation challenges, and conference after conference, even here at APACC, we'll be seeing there are sessions on implementation considerations for PrEP or PEP strategies, right? Even then, we have also CBO sessions, right? The second thing that I want to consider is that communities have been at the forefront of delivering oral PrEP. We have so much data on that. One thing that has been a real gain in terms of oral PrEP is that there's been so much efforts to simplify, integrate, and demedicalize and differentiate oral PrEP as well. And one thing if we are replacing oral PrEP with long-acting injectable PrEP is, where are all these gains going to in terms of demedicalizing PrEP? So oral PrEP, it's like a product that does not need refrigeration. It's something that it can be delivered across communities with demedicalization efforts. There have been a lot of efforts to do task shifting towards non-medical staff. But with the introduction of long-acting injectable PrEP, initial efforts to implement such forms of PrEP involve a lot of potential remedicalization efforts, right? We're bringing back into clinic settings. We're trying to create new pathways within clinics to actually deliver long-acting injectable PrEP. Where are all these gains going to go if we were to replace oral PrEP with long-acting injectable PrEP? That's something that I want to leave you as a thought, in terms of where we are today. 30 seconds. Okay, I've got 30 seconds to give you my last slide over here. So one final thing is the health financing aspect, right? So this is the next scientific aspect. We have a lot of promise in terms of powerful long-acting injectable PrEP products that are upcoming, right? However, I think this is still something that needs to be critiqued, needs to be interrogated as well. So, while there are royalty-free voluntary licensing agreements with generic manufacturers around the world, however, scholars have also pointed out that while almost all countries classified as low-income or low-middle-income countries have been included, there's inconsistency in this approach. And here in Asia Pacific, for example, Thailand is included, but Malaysia and China are not. So there are some inequities over here. And my final point is that most of the HIV infections, or a big chunk of it, would be from countries that are not included in these agreements as well. So I'll leave you here with these points, and I'll move over to our next presenter. Thank you.
Thank you, Rayner. So next we invite Dr. Kumar to the podium.
Good afternoon, everyone. So thank you again, the scientific committee and Annette, for inviting me to do this. And you heard very well from my teammate and partner, Jennifer, stating that the community definitely needs something different. What's currently is been implemented is not going to be helpful to them. So today, I'm going to speak to you in the next 5 minutes or so is why we need long-acting injectable PrEP, which should replace oral PrEP. So if you look at this particular graph, these are the studies from various PrEP trials in the past have shown if you don't take it, it's not going to work. Now, I'm a true clinician taking care of patients for 3 decades. Very difficult to get 100% adherence, even in my patients with so much of support, adherence counseling, and so on and so forth. How we expect this type of adherence in a negative people, for prevention? It might be impossible. And again, if you see these 300,000 new infections last year in our region, Asia Pacific, 21% of the global new infections from our region, despite all this implementation of current, oral PrEP. So it's not going to work. So what's now on the plate is, we have got new injectables, long-acting, we have got implants coming up, and antibodies, and so on and so forth. And again, you heard from Jennifer very clearly that community needs something different. We're not saying that we have to, throw away, the oral PrEP, But the community needs, you heard the studies from different Asian countries, something needs in the form of something like a long-acting injectable. Now, going into the science, as everyone here knows that, cabotegravir long-acting is now part of the guideline, is all based on these two different pivotal studies, one called HPT and OA3, done in, in women, and HPT and OA4 in, HPT and OA3 in MSM population and OA4 in cisgender women, which both the studies very clearly shows it is superior as compared to oral, PrEP. There is no doubt on that. But based on that, FDA recommended to give this every 2 months. Again, for persons who don't want to have every 2 months, they want to have for a longer time. Now, we do have an option. As we all know that you heard from these conferences that lenacapavir is now developed as a subcutaneous, and studies have shown for treatment, both for naive and experienced patients, really works well, especially in people who needs long-acting injectable. Again, having said this, there are a lot of developments happening, more and more availability of this. Just to support this, of this long-acting injectable, we heard this very nice study which was presented last year and now published from Sub-Saharan Africa using this lenacapavir in the PURPOSE study. What they have shown in that is they compared this against the oral PrEP, and a very large number of women who got a high risk for infection in South Africa. So what they very clearly shown in that is, in oral PrEP, they have seen almost a prevalence is based, as compared to the background, incidence of HIV in those particular population. When in this particular trial, in long-acting subcutaneous every 6 months lenacapavir, almost 0 infections, and also they found it's been statistically significant against the background population and as well as against the oral PrEP. This very clearly shows that this is a way forward to implement in our setting as soon as possible without any delay. For someone who needs for every year, they like to have a different thing, every 2 months, every 6 months. Now again, the manufacturers are developing every year long-acting as an intramuscular. The one what we have is subcutaneous, this is in pipeline, and again, early studies have shown there's every potential that it can be a long-acting PrEP. This is something what's been on the pipeline. So I'd like to conclude stating that there is an urgent need for this long-acting antiretroviral for PrEP in lower and middle-income countries. Based on the studies, you just heard from Jennifer from the community, and as well as the science studies from my presentations on some of those newer drugs. There are cost-effectiveness studies have been done. Our early debaters said about inequality and as well as may not be available in resource-limited setting because of the cost and so on and so forth. Very nice APACC cost-effectiveness studies many years back have shown any long-acting injectable, when it has been implemented, it's going to be expensive. Cost-effective is different from cost-saving. Now, if you put in this model, in the APACC model, what they have done is the cost of the medications, cost to prevent transmission, cost to manage the HIV-related complications, all put together in the model on a long run. Anything, even which is marginally expensive, will be more cost-effective on a long run. At the beginning, you need a small-term, short-term fiscal planning to get these medications, but on the other hand, you'll have a long-term benefits out of that. And also, not to forget that generics on the pipeline. I'm from the land of generic manufacturers, India, where we personally feel that it might be available sometime in mid-26 or definitely by early 2027. And today, just now, there is a paper been published by Andrew Hill in Lancet HIV. Very clearly, they have also shown about the cost reduction. I will preserve at the end when whatever our other debate are going to talk about this. With this again, thank you again for this opportunity. So I still have 30 seconds. Probably you can give it to me at the end. Thanks.
Thank you, Dr. Kumar, and Danvic will be our final speaker for this part of the debate. Danvic?
Good morning, everyone. I would like to apologize first if I would be speaking very passionately about this topic because I myself am a PrEP user. But in terms of the motion that we're set today, I would like to thank our colleagues on the pro side detailing about the evidence and everything that has been said, especially about its effectiveness. But first and foremost, being technical and in faith to the motion that if long-acting injectables should replace oral PrEP, we can be clear that first and foremost, we are not against long-acting injectables. We believe that they are a welcome addition, but replacement is totally wrong in the direction. If I would be summarizing how my colleagues pictured the rollout of long-acting injectables worldwide, it would be as simple as this. You know, I go to the clinic, access my injections, and I'll have a happily ever after. But unfortunately, it looks more than just that. There are so many problems that are attached on how we access our services and takes us from this idealized version. Again, we face even these similar challenges even with oral prep. That's why we have these challenges today. And we'd like to frame our argument in terms of how we stand. This is not a question of either or. It is about expanding options, not eliminating them. In a region as socio-economically and politically diverse as the Asia-Pacific region, replacing oral PrEP with long-acting injectables risk undermining progresses that we've already made. In the next few minutes, I will walk you through the 3 core reasons why it should not be replaced: cost, convenience, and confidence. Unless we are all crazy rich Asians, this will not be a problem. But it will be a problem. Let's start with costs. Nothing in this world is free. It has to be paid for somewhere. Long-acting injectables like cabotegravir and lenacapavir are significantly more expensive than generic oral PrEP. Most countries in Asia-Pacific rely on donor subsidies or limited health budgets. Can governments afford this shift? Can even our clients, can I afford this shift? And what about the priorities of our communities, many of whom are living in uncertainty? I would prioritize for my survival, I will prioritize for my food rather than my sexual health. And for someone choosing a PrEP injection and my next meal, sexual health may take a backseat. And if we replace oral PrEP, we might be leaving the most vulnerable behind. And as contextualized by my colleague in my same side, why demedicalization matters. Oral PrEP has earned successes because we have worked hard to demedicalize it. We have built our systems that allowed it to be accessible in community clinics, in mobile units, in peer outreach activities, even pharmacies, even buses. There are so many examples in the Asia-Pacific region that we are able to roll out PrEP in a very demedicalized manner. In our organization alone in the Philippines, we are even offering it entirely online. They don't have to go to our clinics. It was easy, discreet, and empowering, especially for those avoiding judgmental or stigmatizing healthcare settings. However, long-acting injectables might bring us to clinical dependency, trained staff, cold chain logistics, scheduled appointments. And most of our systems are not even ready for this. And many of our clients don't feel welcome in these clinical spaces. Convenience is not a luxury. It is a precondition for uptake. Which brings us to the reason, why did we set up communities giving PrEP in the first place? Because the mainstream system wasn't built for us. It excluded us communities. It stigmatized us. Our communities created spaces where people could feel safe, respected, and seen, not just by patients, but as people. If we shift HIV prevention back to clinical systems, we risk destroying those safe spaces. Long-acting injectables may require clients to go back into environments that they actively avoided. Confidence is not just about trust in a drug. It's about trust in a system that delivers the drug. So here is the bottom line, and I have 1 minute to finish. Long-acting injectables are promising. They are indeed very promising. But replacing oral PrEP with them would create barriers, not bridges. We must protect choice. Different people need different tools. Some of them will prefer pills. Some of them will prefer injectables. And that's completely okay. Let's invest in building a system where these options coexist and where everyone, no matter where they are or where they live, can access HIV prevention that works for them. Because we fully believe that the best HIV prevention option is the one that works for you. Since this is a scientific presentation, these are my references, and thank you very much for listening. Arigato gozaimasu.
We had 4 very passionate defenses of their proposition. And now if we could have the lights up and we can have people with the microphones available, we're going to take some time now for people to ask questions of our debaters. So please feel free to raise your hands if you would like to ask a question. And so maybe I will start while we're waiting for people to gain the courage. And then Joe, a microphone down here to the front, please. So the question for Danvic and Rayner, we've had oral PrEP for how many years now, and what percentage of people who need it are taking it or have initiated, and what percentage, meaning more than half, stop by month 6? So why should we continue with oral PrEP if it really hasn't been scaled up to the level we need it to be?
Testing. Okay, thanks so much for the question. I think that's also something that we are trying to argue for, right? I think one thing is that we recognize that oral PrEP has been around for a while, but we're still in the midst of scaling it up. That's something that we've pointed out. We're still at these conferences fighting for and advocating for the scale up of oral PrEP, access to oral PrEP. And the one thing is that we haven't actually achieved that goal of coverage in terms of oral PrEP alone. So this is something that we're arguing as well, right? If we haven't done that, why are we introducing something else to replace oral PrEP? We're not saying that we should actually, not continue oral PrEP. Actually, we are for the fact that we have more choices, right? If we have long-acting injectable PrEP, we will be able to fill some of these gaps that when it comes to adherence for oral PrEP as well. I think one thing that we are arguing for is that power of choice that my colleague Danvic has been talking about.
Thank you. So we'll go to microphone 3 first. And please introduce yourself.
Thanks. I'm Joe. You guys know me. I loved all 4 of these presentations. They were fantastic. It seems like there might be some differences of opinion. I'd be keen to hear from each of the groups about one thing that you share. What's one thing the other group is really getting right? What do you acknowledge that they actually got right? And don't give me a but. I want to something that you genuinely agree with them on.
Oh, seeking harmony in dissension, Joe. Okay, so maybe we'll have Jennifer speak on behalf of their side, and then Danvic speak on behalf of the other side. Push up.
Now, I'm absolutely in support of tools and whatever tools that we need being available at the community level system. So I absolutely hear that. Think about HIV treatment, right? That the cost, the implementation did not stop us from pushing forward. And we do. Why keep trying and using something that doesn't work? We haven't fully scaled up PrEP, like oral PrEP. It doesn't sit well with me. We're running out of time. I gave you all the figure. Our region is absolutely behind. Philippines, you're 500% plus increase in HIV infection. Do you think you have time to wait? Right? So I absolutely believe, and I think with between all the multi-stakeholders, we can find a way to also make injectable as part of the community-led, community-based services, how we integrate that with the whole medical community. So I absolutely in full support of being community-led, community-based, and community being a center of this conversation.
She didn't say but. Okay, Danvic?
First of all, we believe in the evidence. I would not even be accepting the WHO co-chair for CABLA if I would not believe in the evidence. And this evidence actually fills out the gaps that we are currently seeing in the rollout of oral PrEP. But I think what we're not seeing right now is, yes, like for example, in our country, we have a 542% increase in HIV cases as compared to 2015. But if you could give me CAB-LA and lenacapavir now, so that we could roll it out to our country now, then definitely we wouldn't be running out of time. But you know, in terms of discussions, it will still be a few years from now. So in terms of how we roll out those options, we still think in the current systems that we have and recognizing the different economic and systems that we have in this region, we still believe that the best HIV prevention option is the one that works for you.
Thank you. Microphone 1. Oh, no, microphone 4.
What happens is whenever something new comes, that is in addition to what is existing. And we made the mistake earlier. When condom came, we lost the track of monogamy or partner selection. Then when PrEP came, we lost the track of condom and all STDs went up. Now, long-acting injection coming, we are losing the track of PrEP, which is available as tablet. Secondly, availability from India, cabotegravir has been licensed 22. Till today it is not available. This is licensed for 4 companies in India. Till today they are not going to make it. The cost of $22,000 versus they are not yet to decide whether it will be $100 or $500. So whatever new is coming is in addition to what is existing. So there are good devil's advocates. They are saying that yes, this is best and forget about that. All are passionate, but I think anything new is coming is in addition to the previous existing prevention modes.
Thank you for your comment. Microphone number 1 and another microphone down here. Number 1 first.
So my question is for the against side. Is there a length of time for the injection to be effective at preventing HIV that would switch your position? So we're talking in the moment about like 2 months, 6 months, but if we're talking about like, you know, your 3 Cs, your cost, convenience, and I'm forgetting the last one, confidence. If you had an injection that lasted for 3 years, would you change your mind? Would you replace your oral pills if you get an injection that lasts 5 years? I'm just curious if the length of time and the cost, if those levers change, if you would flip your position.
Danvic, since you were the 3 Cs.
If we have that right now, then let's talk again. I guess this is where science is very important. It constantly changes. It constantly evolves. And our learning should not stop. There are times that we need to unlearn stuff so that we could accommodate new stuff. But until that time happens, our position still remains.
Microphone number 3.
Hi, Iskandar Azwa from University Malaya. I just wanted to offer a peace option for both groups, and maybe you could comment. One of the solutions to a new point of neutrality would be the long-acting oral pill, which is being created by MSD. So it's an oral option, and it's given every month. So maybe a comment from the pro-injectable team, from one of you, and as well as from the con team. Thanks.
We have been talking about long-acting injectable every 6 months and 12 months. So definitely every month is on pipeline. And also there are other options from the same manufacturer every 2 months and every 4 months. So it's all long-acting. You know, either you are giving us the injectable or as a, you know, oral tablet. But here our option is long-acting. You know, only thing now the approval is injectable. That's what the title is. We all know injectable. I agree with you. I think we can have a choice when it is available on long-acting, like an oral tablet every 2 months or, you know, every 6 months, probably that kind of thing.
Rayner?
Okay, I'll go first. No, I think this is the importance of offering choice. That's why one option may not work for a certain area, one option may work for a certain area. And I think that's important to recognize our differences because let's face it, we are very different in our health systems. We are in a very high-income country. We are from a very middle-income country. And, offering these different systems will enable access to everyone. So definitely, if more options are available, depending on how our community should access it, then definitely that's most welcome.
And I just wanted to add real quick also, I think, the premise of this debate also is that, injectables introduce, new forms of considerations for implementation. So I think that would be a different discussion for another day. Actually, I also want to point out that we're all really at peace with each other, right? Actually, I do not disagree with anything that the proposition has said, except for the definition of replace.
Microphone number 1.
Okay. I enjoyed the debate very much because all the press, both sides say very good. That means that must be coexist now. We both are very good. But I have to comment on this, that because the injectable still have patent, not generic yet. So this compare is not so fair. Maybe after generic come out, it will be better discussion for this. And the second comment is that maybe someday we not necessary to discuss this, because the best way in public health is that to make you equal you. You can treat every patient, then no virus spread. Then why prevention for using injector or PrEP? So it may be someday this topic's not more important because no virus spread, because everyone have cover and treated well. Thank you.
Thank you for your comments. Certainly would hope that that would be the case. Microphone number 4.
Hi. On?
Try again. Yeah.
Okay. Hi, I'm Paul Adamson from University of California, Los Angeles. I have a question. I think both sides brought this point up, but probably the question is more relevant for the pro team. But one of the things you brought up, and I think it's a real problem that we all need to work on, is retention in HIV PrEP care. And obviously the having injectables may address some of that gap, but I think there is a concern too about development of resistance, probably more with CAB right now. But how much of the gap do you think long-acting will solve in terms of retention? And then it probably also goes to the con side as well.
Thank you, Kumar.
Thank you.
It's a good question. Right now, we don't have the good data on that, on the retention, but we have enough data on the everyday oral PrEP retention is very bad, as we all know that, enough studies, both from the community and from the clinical perspective. So coming to this on resistance, we do have a few case reports. We had to wait and watch. Now we have, there are risk factors on that, so that also has to be factored in, not just they develop a resistance because of the previous exposures. And also now we have other long-acting like the Nagapavir, which they have not seen at anything on that resistance. And also there are a lot of newer stuff on the pipeline. So I think we should not at this time, a very useful and important tool, and how it can replace currently, which is not doing well in terms of oral PrEP, So that's what we should look at as a take-home message.
I'm actually going to ask all 4 of you to talk about this question of retention. So maybe Rayner or Danvic first, then back to Jennifer.
Okay. So I thank you for the question. Actually, I think PrEP data in general, regarding whether it's an oral PrEP or a long-acting injectable PrEP, is not high resolution enough for us to make such bold statements as to replace one kind of a prevention modality over another. Even for oral PrEP, we do have a lot of data in terms of real-world implementation. However, one thing that as a social scientist I also question and interrogate and challenge is, we often take this very paternalistic view on that people should stay on PrEP all the time. That retention is about making people stay on PrEP. However, we do not collect enough data on what people's relationships are, what their sexual behaviors are in conjunction with PrEP use as well. So there's stuff on like adherence, effectiveness. I think I forgot the term, but it looks at people's sexual behaviors and needs in the context of PrEP use. And I think that's something that's really important to collect, but we don't actually have that kind of data across many settings yet. So to say that retention and adherence is an issue, sometimes I have a question mark there. And I say that also because in places like Singapore, we see our HIV incidents actually dropping year on year. After we've rolled out PrEP, with U equals U available, but also we see issues with adherence anyway. With retention anyway. Our recent studies on like young men who have sex with men in like a clinical setting show that retention is an issue. However, people are still using PrEP and gaining access to PrEP and using it in ways that are useful to them. So that's something that I would question. And I think just a very quick point that I also highlighted: we do not have enough data on long-acting injectable PrEP, in our region to actually allow us to make some of these recommendations as well.
Jennifer, and then Danvic, and then microphone 3.
Thank you for that really great question. And I think this is where community comes in, right? And with long-acting injectable or oral, like communities have been trying to make oral PrEP work. And it has been a really, and especially with the current funding situation, I mean, we're seeing a lot of community-based, community-led services going away in our region. And that is going to create even a bigger gap when it comes to retention in the coming next 6 months. So with long-acting injectable, it lessens the burden, the number of return follow-ups we will have to do. It lessens the burdens on the medical health systems as well. People don't need to return as frequently as possible. So I think while we don't have data, and I think this is where we need more data, right? And it doesn't mean that we should not move forward with long-acting injectable. And so this is where I stand.
Something I agree on with the pro side. We need more data because we know for a fact that there are people who are not staying on PrEP. But the real reasons why are they not staying on PrEP, that's where we are blinded somehow. And being not on PrEP somehow, I think it comes from a context like on how we worked on rolling out HIV treatment. You need to stay on treatment. You need to be still on the cascade. So I guess that's where our paradigm is also somehow attached to, that people need to be on PrEP all the time. But we know for a fact that PrEP can protect us from our seasons of risk. But not everyone is always on the seasons of risk. And I think we need to understand more the totality of why people are not being retained to PrEP so that we could really achieve more solutions that would work for the communities that needs them the most.
Thank you. Last question, number 3.
Hi, Tom Fitzpatrick from the University of Washington. My question is for the pro side. And in particular, I'd like you to talk to the corporate interests that are involved in long-acting injectables. Right now, long-acting injectables are largely controlled by relatively few big pharma corporations. And so how does supporting your proposition not make us overly beholden to corporate interests?
So, we have science which shows that, right? So, but we have one manufacturer. So I mentioned that 4 other manufacturers are given license, and today you can see tonight Lancet HIV, what will be the cost. And I can just open up because just published. So it's been estimated around $36 to $45 per year per person. So it's almost averaging out the oral PrEP. Of course, still expensive, but on the other hand. Again, developing a long-acting injectable is not that easy by the generic companies, but they are putting efforts, technology transfer. It's in the very advanced pipeline. I said about 26. Unless we create a demand, from our region, more and more manufacturers won't come into that. I think this is something, it clearly shows, it'll work. Look at the data on the purpose, 0 transmission, right? And compared to the, oral PrEP, even in a clinical trial setting, the adherence is very poor in these oral PrEP. And it very clearly shows that with all those negative caveats on those everyday oral PrEP, I think we need an replacement, which currently available is a long-acting. So might be like oral PrEP, long-acting might be available, but on the other hand, currently what we have the tool is long-acting injectable, now already approved by several guidelines, including by WHO guideline. Now this is time that how we scientifically advocate, community-wise we advocate, get the manufacturers to our community. Also, our friends argued that it might be very difficult, especially to introduce. Look at the COVID vaccines. We, vaccinated millions and billions. In my own country, 1.2 billion people, half of them were vaccinated, just like that COVID vaccine. So similarly, again, it's a subcutaneous lenacapavir, not that difficult to give. It can be very easily, all types of task shifting and, all those can be done. It's already been done in Africa for various settings. It definitely can be done in our setting. I think this is time to move forward. Science, community needs, and as well as the newer technology, and as well as the prevention.
So briefly, Jennifer, to close.
Sure, thank you for that comment. And you're talking to someone who considers myself as an HIV access advocate. I carry medicines across borders. So, and so I want to use this this opportunity to say to the pharmaceutical, we did not let cost stop us. I want to say this clearly, access must follow innovation. And if you develop a tool that can change the game, then price it like you want it to be used fairly, widely, and urgently. So communities are ready, the data are there, and the system could adapt. And so the last thing that should stand in our way is profit. And here also call out to the government. You have your role to play as well. So let's all work together.
Okay, thank you all for your comments and questions. We'll now move on to the 2-minute closing statements, and we'll go in reverse order. So Rayner first.
All right. Well, thank you so much, everyone, for being here today. Thank you so much, Dr. Sohn, for moderating this entire debate. And just want to actually point out that actually our friends over at the proposition have really shared a lot of data in terms of what communities want. Our friends have also shared a lot of clinical data on why long-acting injectables are really effective. Communities want long-acting injectables. It is effective. It's something that definitely should be rolled out in the future and to be scaled up, right? But actually, what we are arguing, and I just want to reiterate this, is that communities want that, but many people also want the choice to have oral PrEP as well. Many people want the choice, like our colleague over there. Many people also might want to stay abstinent. Many people might also want to stay in monogamous relationships. Many people would also rely on you treatment as prevention, to actually prevent HIV. But what this point shows us is that, I just want to reiterate, and I'm sure my colleague Danvic will also say, this is about choosing the option that works for you. And in a world where we only have long-acting injectable PrEP, that is not what's going to happen. We are only left with one option. So I'm going to leave it here. Thank you.
Jennifer?
Thank you, Annette, for the opportunity, and everyone for the opportunity to be here. And again, we're not taking away options, we're running out of time in our region, and we are at a turning point in the HIV epidemic in our region, with the world's fastest growing epidemic happening here. We cannot end AIDS currently with the tools that only work for the lucky, the visible, and the stable one, right? And so long-acting injectables, they're not just new options. They're smarter, they're more equitable at the default, and they reduce stigma, and they have potential of increasing retention, and they bring prevention tools closer to those who are left furthest behind. So again, it isn't about removing choices. It's about doing what's right, what the science telling us, what people are telling us. So let's not ask if it's possible to make LAIs available, but it's ask like what's the right thing to do, and how can we make it a reality. Thank you.
Thank you, Jennifer. And Danvic?
I think I would like to take this opportunity to bring up a conversation that I previously had with one of our colleagues in the region from IHRI, Rina Jan Amnoysuk, when she shared to me that when people come into the clinics and they would want to access services, when they access the service, it's not just PrEP. It's more than that. When they access services to our clinics, even though as providers, we would want the best for them, and I think that's our best intention, PrEP is not their whole story. And in terms of, and I speak for the communities, sometimes we tend to categorize people that they are at risk for HIV. And if we categorize people that they are at risk, we come from a mindset that what they are doing is wrong. We need to change that paradigm from a directive approach of you take PrEP to an evocative approach, making them think what option is the best for their lifestyle. And I think I agree in terms of the evidence that long-acting injectables would really be a game changer. But in terms of our realities, not only our biomedical needs, but also our psychosocial needs, it's more than just a drug. And I think we have the power, we users have the power to decide what option would be the one that will work for me. Thank you.
Thank you, Danvic and Kumar. Don't you love it? You get the final word. Yes, it's working.
Right. Thank you. So the final word being, we said everything. Coming to these tenofovir-based oral everyday PrEP, as we all know about tenofovir toxicities, right? Both on the bone as well as on the kidneys, on taking on a long-term on a negative people. Again, that's another one will be a negative things. Two things, another second one is on hepatitis B prevalence. In our region, it could be anything from 3% to 9%. Someone who's taking tenofovir for a oral PrEP and discontinuing, there is every possibility of flaring up of hepatitis B infection. Another caveat, unless you know about the status. And very importantly, in the everyday oral PrEP guideline, annual HIV testing or periodic testing is very important, which is currently not happening both in the developed world as well as in the developing country among the everyday oral PrEP users. Now, having these long-acting injectable have every opportunity for them to meet with a provider, either a nurse or a doctor, to get know about their HIV status for a testing. And also, we heard from Dr. Gilada that now STI on the rise among the PrEP users because this PrEP is not going to prevent STIs. Now, there are every possibilities for them to get tested and get appropriate treatment as well as other prophylactic measures like doxyprep and so on and so forth. I think we have a lot of positives on introducing these long-acting injectable PrEP.
Join me in thanking our speakers for their closing comments. Okay, so if we could have hopefully the technology works, the second vote slide, my final slide. So this has been a great opportunity to consider the pros and cons of the proposition as to whether long-acting injectable should or should not replace oral antiretrovirals for PrEP in the region. So if you could please go back to that QR code up there or enter in the URL for the Mentimeter and the code. We're going to ask you to go ahead and you can vote right now. Don't show the slide yet, but you can vote right now. And I think as Joe started us off by saying, can't we get along? And in fact, they do get along, and there's a lot of pros and cons to this topic, which is why we felt this was a good one for us to debate. A lot of these issues were raised during the course of the conference over the last two days. Wow, it feels like longer. And whatever happens with the results of the debate, I know that this has caused us to think more carefully, more thoughtfully about the different perspectives that are involved, from the client within the community and their needs to the provider, to the medicines, to the cost effectiveness. And so hopefully everybody has had a chance now while I've been talking to enter your vote. And let's see, are we technology people, are we okay to show the results of the first vote? First? We're good? Okay, thank you. So we're going to show the results of the first vote first. And we had yes, long-acting should replace was 44%, and versus 56% that said no, it should not replace. So that's a difference of 12% at the moment. So let's see the second vote, what the result, whoa! I don't need to do the math. My goodness, so it looks like the no team convinced more people.
So Annette,
big round of applause.
Annette, this is a typical example of the U.S. elections.
Well,
Yeah.
okay.
So-
So I think
You
what
want to
this...
have a bad president.
What this shows us is that, first of all, coming into the debate, you were pretty evenly split, fairly evenly split between yes and no. And after the debate, our people on the no side, whether it was because they clarified the definition of replace versus what they shared about the importance of options, taking time, engaging with community. And at the same time, we had our long-acting pro team explain to you that we are really behind on prevention. The results of this debate do not change that. We really need to make changes in the Asia-Pacific region. People think that because we have high-income, middle-income economies, countries within our region, that of course we should be doing better, when in fact, as Jennifer said and Danvic acknowledged, between 2010 and now, there's been a 500% increase in the incidence of HIV in the Philippines. How do we square that with what we are seeing around the world, where reductions are being seen in East and Southern Africa, which has much greater burden, but also up until now much greater donor support? And now, given everything we've been talking about the last few days about changes in domestic and global funding for HIV programs around the world, that improvement may reverse, and we're very concerned about that. But within our region in particular, this issue of incidence among especially people who consider themselves within high risk or key vulnerable populations is very serious. So hopefully, whatever side you came on, whatever you voted, that we can all agree that something we all need to continue the work that we do, whether it's in research and data gathering, implementation and service delivery, engagement with communities, and advocacy with our governments and with our funders and donors and companies. We all have a role to play, whoever you are. So thank you all very much for your support for today's debate, and one more round of applause for our speakers.